The bulk of my inspiration comes from the patients themselves. These patients are phenomenal people. They have been self-selected. Many of them have seen other orthopedists who are not either interested or capable of dealing with these complex problems, and they've found me. So they're completely dedicated to getting better. They are intelligent people. They have been through tremendous trauma, both physically and emotionally, and their strength gives me the strength to want to do everything I can to help them. If you ask anybody who works at the hospital for special surgery how they feel about working there, everyone will tell you the same thing. They say it's an incredible honor to be able to work at the hospital for special surgery. And from the x-ray techs to the janitors to the nurses to the doctors, everyone feels the same way. And with that vibe in the hospital, it makes it an incredible place to work and a fantastic experience for patients. Everyone here is completely dedicated to something greater than themselves. We all feel like a part of a fantastic entity that delivers top-notch healthcare. So that's fantastic. Other than that, the hospital has been very supportive of our institute and has helped us have a fellowship, has helped us obtain physician's assistants who we've trained and are experts at post-op care using these techniques. We have anesthesiologists that are dedicated to us who know how to manage pain, particularly post-operatively, for our patients. So we've really set up a fantastic program here at our institute at the Hospital for Special Surgery, which makes this complicated, different procedure routine and safe. One of the most exciting things that's coming in the future is in the treatment of arthritis, particularly in ankles and perhaps in the knee as well. A technique that I use is called joint distraction, where we use one of these external devices to actually put traction on the joint, and this has been seen to help regrow cartilage to some extent. Very popular in Europe, now becoming more popular in the US. This is one of the few centers that does this procedure with great regularity. And in and of itself, distraction has been successful with good success rates. But combined with other techniques, I think that distraction really holds a place in the future of care of all arthritic joints and joints who are at risk for arthritis. Hopefully we won't all get arthritis. But some interesting innovations are the recognition that certain joints are more at risk than others for developing arthritis. And some of it has to do with genetics. Do your parents have arthritis? Some of it has to do with the patient's weight, their activity level. But something that we can control very well is the patient's limb alignment. And I'll see patients who have bow legs, who have tremendous arthritis on the inside of their knees because there's just too much pressure there. And by straightening the legs, that takes all the load off the arthritic joint and decreases their pain tremendously. On the prevention side, if we can identify these people even before they develop arthritis, when they're young adults, and straighten the legs, correct the bow leg, correct the knock knees, then there's a significant body of evidence that shows that they're much less likely to ever even get arthritis in the first place. The technique we're using for bone transport and distraction osteogenesis is really an evolution of the original technique introduced by the Russians to the United States in the late 1980s. There's very few centers that are able to use the computer-assisted external fixator and a mixture of internal and external fixation techniques. Here at the Institute for Limb Lengthening and Reconstruction at the Hospital for Special Surgery, we're using these techniques. We're cutting down on healing time. We have a great relationship with the endocrine department where we're getting people on the right medications to help the bone heal faster. A new technique that we're using now is an office procedure where we inject the lengthening site with platelets from the patient, and that also speeds up the healing. This is a model representation of the bone transport procedure. The bone defect is down here, and this is where the bone is missing. This is where the skin and soft tissue are very injured. This won't heal by itself. Up here, we go to a fresh site and crack the bone through a minimally invasive incision and slowly transport it down at 1 millimeter a day until we get docking down at the distal docking site. This area up here then fills in with all new bone.